All right, what a surprise. I have Melody. You listened to the COPD episode, and we decided last minute to come on and have what you Canadians call a fireside chat. That's actually an American term. That was FDR.
Well, we've obviously hijacked it and use it as well. But no, like you can't talk about CPD and expect me not to like chirp in your ear and be like, "Come on, let me on."
Please, what do you got to say?
Honestly, I think the episode you had was awesome. But I know that COPD is kind of this wild and wonderful
Thank you.
disorder that can present so like with so many different varied like ways. And because of that, it can cause a lot of confusion for people that are like responding to that initial phase of like shortness of breath and like not necessarily knowing what pathology is the problem that's causing it. And it can be like those high adrenaline calls where like this patient's like within an inch of dying and you don't necessarily know which way to go. So it kind of is something that's very near and dear to my heart. It's something that I see very often. And yeah, I definitely understand the pucker moment when you walk into like seeing a patient that's in an acute COPD exacerbation and then not necessarily know in the maybe limited bag of tricks that you have, how you then go about treating this patient. So like the case you gave was an excellent one because it's so common that I see that exact patient in emerge, and then giving practitioners kind of an at the bedside approach on how they can direct their treatment according to what they see from their patient.
The emerge. It cracks me. I still will laugh every time you say emerge, another
Yeah.
Canadian thing. By the way, people couldn't tell I'm sick. So if they see the video of this, me constantly blowing my nose. All right. So take us through how you, as an RT, approach these patients.
Like the way you mentioned about like you start off with just like bread and butter auscultation, and you're so right that often these patients present with like a washing machine in their chest and you're like, what the hell? There's crackles, there's coarse wheezes, there's like inspiratory like high-pitched wheezes, and you're like, what is going on? So, and it's kind of the bucket that is COPD, right? Like you can have bronchoconstriction, you can have mucus rolling around in there, you can have some pneumonia on top of that that's causing some consolidation. And then overall, you also potentially have distal airway collapse from just the disease process causing like changes to the terminal bronchioles and like just this floppiness. So they really can present in a variety of different ways. Then you also have the fact that their diaphragmatic muscles are not necessarily as strong, and they are just kind of on this like cusp of failing. And so how do you then go? So like, yes, if you hear wheezes, like absolutely, there is absolutely no harm and no reason not to throw them on some type of like either a nebulizer, MDI, whatever is your poison, pick it and give it to them, because most likely they do have some constriction. But then what? Like, do they have some mucus that you can't necessarily suction and clear because they're breathing spontaneously and you don't want to bug them? But then like from there, directing your therapy really for me comes down to how do they present. If they are looking like that goldfish that is like guppy breathing with this high like inspiratory demand, they're just sucking air back, they are literally telling you that they want flow. And like, I loved how in the call that you mentioned, you were talking about oxygen for your COPD patients. And it is so true. Like, make sure you're giving oxygen and titrating to SATs, but just reminding people that oxygen is a pulmonary vasodilator when they are hypoxic. So
I thought it was a constrictor because they
so
teach that in ACS. They say don't give it to your chest pain patients because it's a vasoconstrictor, but you're saying pulmonary system. All right, explain
yeah.
that.
So it's a pulmonary vasodilator, but it's a systemic constrictor. So it's reverse in the pulmonary system.
Okay.
So, and a good way to remember this is when you're thinking about neonatal circulation, they have high pulmonary vascular resistance. As soon as they breathe and have room oxygen that is higher concentration, that flips and causes pulmonary vasodilation, which then flips all of the PDAs and pressures in their lungs and dilates everything in their lungs to have them actually ventilate and have blood flow to their lungs and flip their circulation. So it is a pulmonary vasodilator. So with that, when you have patients who are hypoxic, you're going to end up having insufficient pulmonary circulation. So you want to increase their pulmonary circulation to allow them to actually oxygenate and exchange oxygen in their lungs. So hypoxic patients, that's a bad thing for their pulmonary circulation, which is
Okay.
obviously going to worsen your VQ matching. But then systemically, absolutely, it's vasoconstriction.
Okay. Okay.
So yes, oxygen first. It's going to improve the blood flow to the lungs. And then with the fact that they're asking for flow, now that you've given them oxygen, and that's potentially helping, just improve blood flow to their lungs and that therefore gas exchange, then you can start to address that work of breathing. So you're already giving them treatments, trying to, dilate any of the muscles in the lungs of the airways themselves that are tight, but then you want to actually work on the work of breathing, because we know that their diaphragms are going to be weaker. Their extra accessory muscles are probably already taxed. So now you need to try and decrease that work of breathing. So then this comes down to, what bag of tricks do you have at the bedside? So whether you only have CPAP, whether you have so many options, you have high flow, you have CPAP or BiPAP, then it's about choosing your therapy according to their work of breathing and how much support they need. So from here, if you have all of the different therapies, my suggestion is start early with high flow and then transition them to non-invasive if they are still working and not reverting. But if you only have CPAP, then give them the flow that they want and go to sleep.
Nobody has high flow nasal cannula in the U.S.
Not even critical care providers?
At least EMS. Yeah, but critical care providers aren't responding to these COPD exacerbations like that generally. We're more going to people's houses. Critical care, they're already managed in the hospital.
Yeah,
so they're pretty far down the pathway. High flow nasal would be a good thing, maybe in the future.
Yes. Though that caveat being, anyone who wants high flow and has a hard on to get high flow, if they're like an EMS service, you absolutely have to have heated humidification,
100%.
active humidification, or else you're just going to cause nosebleeds and no one's going to tolerate it. So if you can't have one without the other, and then that has this whole cascade of needing external batteries and all that. But anyways, I digress.
I will say in the US, it is encouraging that it is, I mean, I only see my perspective in the Mid-Atlantic, but it seems like most services are getting access to ventilators, so they can do BiPAP now.
I love that.
Becoming more mainstream.
Yeah, and I had someone reach out to me recently about one of the mask CPAP units that now is able to give BiPAP, and I'm very curious to actually get my hands on it because I want to play around with it, because it looks like, what I want to know is whether it senses the patient's effort, and that's the thing that I haven't yet decided, but TBD, I will figure that out, because I'm super pumped that might be more readily available, because yes, these patients, they want inspiratory flow, and remember that CPAP does not really give that inspiratory flow. It has just that positive pressure that does not change with inspiration. So the one benefit of knowing whether CPAP will work for you is looking for one clear-cut sign that is telling you that they want just CPAP, and that is pursed lip breathing. If you see pursed lip breathing, that patient is literally telling you what they want, and CPAP will 1,000% help that patient.
Why?
Because they are actually they're
generating PEEP. Yes.
Yeah.
Okay.
So when you think about pursed lip breathing, it is essentially breathing out through a restriction. So they are causing positive descending pressure as they are breathing out through a restriction. It's the same thing about, a Valsalva maneuver, breathing through an open syringe. If you just pop out the plunger and have them breathe into it, it's the exact same thing. They are doing that to themselves. They are causing that restriction, which essentially is CPAP. So a classic sign with COPDers, for the ones that have those floppy airways, they have literally learned how to do that themselves and distend their airways. And that is with pursed lip breathing. So if you see that and you only have CPAP, just go right to CPAP. You know what they want.
Okay.
And then if you have BiPAP, again, I always highly suggest, and you mentioned on the podcast, that BiPAP really is the fix, because once you get a COPD exacerbation that is cycling and is in a situation where their CO2s are elevated and they're failing, they want that inspiratory help, which BiPAP would then help.
All right. What about meds wise? I mean, nebs. I'm trying to dispel this whole dogma that you're going to cause congestive, pulmonary edema by giving a neb, which I don't know where that came from, but it's been old medic dogma.
Yeah, it was funny. I didn't hear that at all until I started working in flight, and I was working with paramedics, and a paramedic asked me that, and I literally was like, huh? like I never heard
My
that.
my theory with this, and somebody echoed this in the comments on my thread. I have always said that I think that you show up to a wheezing, shortness of breath patient who has crashing CHF. You hear wheezes, so you go down the whole bronchoconstriction pathway. Meanwhile, you should have gone down the nitro PEEP pathway, and then they decompensate because you were lulled into thinking this is just bronchoconstriction, it's COPD or it's asthma. And then, yeah, you will see some pink frothy sputum when they decompensate. I think it's totally coincidental.
Yeah,
That's just my thought.
I can tell you right now that like I regularly see those core pulmonale like COPDers where you really don't know what it is, and like they sound wet like as a sponge, and but we're still treating them with NEBs actively or with MDIs actively, like it because we're really not sure. We're trying to kind of hit them from both sides. So often that patient, I throw them on BiPAP and I'm hitting them over and over with MDIs, and like I'm not seeing pink frothy secretions. Like I'm just treating them both ways because I don't really know what I'm dealing with.
Yeah.
And a NEB has never hurt anyone. Like seriously, other than causing a slight VQ mismatch for a periodic time, which is very transient. Specifically in kids, you'll see them drop their SATs slightly by 2 points, but you just give them a bit of FO2 to like band-aid that, and then they revert and they're fine.
Well, that's good to hear from an expert because people don't seem to understand that. I think people are coming around more to it. It's more like old medic dogma, and I'm not shitting on the old medics, but yeah, I mean, there's no harm in it. Open them up a little bit, and if you can better appreciate what's going on in their lungs once you give them a NEB treatment, then if you got to switch to a CHF pathway, go down a CHF pathway. And who's not to say they don't have both going on?
Yeah, and at the end of the day, like I am a huge advocate for early BiPAP and getting those patients. Again, if you have BiPAP, and even if it's a COPD patient that has the pursed lip breathing and you have them just on CPAP, like if that's all you have, like do it, like absolutely do it, because it might be enough flow to satisfy. If you're giving them oxygen already, it might be enough to get them what they need until they can get to BiPAP to then fix the potential accumulation of CO2 you've had. So like I am all for it. Just like it's not going to hurt them.
Let me throw this. Let me throw a steroid thing down your way. Here's two things we hear. One, they're now saying to do half doses of steroids. I don't know if that's come your way yet, but it's kind of, they're saying we are causing too much hyperglycemia, delirium, fluid retention, all that. So they're going to half dosing of steroids in some places. The data is not that great on it, at least what I read and talked about on the podcast. But the second thing you hear from some EMS training programs is if you think they have an infectious pathway or pneumonia, don't give them steroids because you're going to cause immunosuppression, which kind of makes sense at face value. But real world, they're giving steroids to everybody. And these patients, these chair-dwelling COPDers that are putting 3 packs of parliaments down their bronchial tree every day, they've got a bunch of pathogens in their airway to begin with. So what are your thoughts on steroids?
It's honestly in my gold standard treatment of COPD patients. Like as of now, I haven't seen too much of the half strength steroids. I'm still seeing us give them 125 solumedrol like every single time. And for us, like we hit every single COPD exacerbation with antibiotics because they probably have a concurrent infection at the same time. We're giving them the steroid and we're giving them MDIs. Like every single person that is short of breath with COPD history across the board, that's what they get.
Yeah. What about MAG?
I love that you brought that up because I don't think there's much harm in throwing it in. And I think there's something that's sometimes underappreciated is the fact that you can have, like, when you have a really severe asthma patient, they end up having chronic lung changes that end up having them present on X-ray, on CT, on all of their findings. They end up having lung changes that make them then get a COPD diagnosis on top of. And I find as clinicians, we often hear COPD and jump right to COPD treatment and kind of miss the fact that they actually are asthma COPD that's caused that COPD, which then makes MAG absolutely like critical for them to potentially move up in their pathway. So it's kind of like one of those things of like, what's the downside of a mag dose if they are severely short of breath? Like, obviously it's not within my first bucket, but if they're still
Sure.
constricted and I'm noticing one of my favorite words to say, if I'm still noticing polyphonic wheezes when I listen to their lungs, then I absolutely would advocate for mag.
Well, that's where like my quick and dirty, like Mongo caveman medic assessment and decision-making pathway comes in. I don't care what's wrong with them. I don't care if it's COPD, asthma, pneumonia, a combination. I've always just equated severe shortness of breath and really bad wheezing with, hey, I should probably give this person mag once I get other treatments going. I don't know. Am I right? Am I wrong? I don't know.
But I don't think there's really a wrong for mag. Like, yes, like if their mag was high, sure. Like maybe there is a downside or if they're hypotensive, but like
Mhm.
it's a very like low risk medication. And yes, it's not first line, but once you're getting to the point where like you don't have any, like you're twiddling your thumbs because you've done what you can do and it's a drug you have available and you have an option to patch for it or to figure out whether there's an option to give it. Like if there isn't a contraindication, what's the downside?
All right.
Whether it works or not.
Let me throw you one other curveball. I didn't talk about this on the podcast, and I kind of wish I had, but it would have been too long. What are your thoughts on patients who are really air hungry? They're freaking out when you put them on BiPAP. What are your thoughts on a little dose of a benzo to help them tolerate the BiPAP and chill out a little bit?
Yes. Though I would argue, is there a way that you can get them to tolerate it without it? And I think
100% agree with you.
I like when a lot of like, again, I teach this to critical care paramedics. Like that's my job on a regular basis. I teach critical care paramedics and it's something I see a lot when I'm auditing charts and stuff of using sedation in order to get someone to tolerate NIV. And I can truly count on one hand how many times I've had to reach for sedation with non-invasive.
Okay.
Now, and again, like it doesn't make me the be all and end all. Like I still have a lot to learn. There's always more you can learn. But I think one thing that I am very good at is being able to prepare patients for what they're going to feel and also be very comfortable in starting extremely low with a therapy and slowly increasing while they get comfortable and coaching them through that process. But if you're still like for kids, for example, you can't coach them. So absolutely giving them a dose of something to help them tolerate is definitely needed. But then I would advocate maybe you want to go with something that's a little bit, I'd probably like consider Ativan, something just an anti-anxiety med, or then potentially going out with like a ketamine dissociative medication in order to have them tolerate and keep their drive.
All right. Well, do you have anything else you wanted to bring up?
No, just like for those EMS providers that only have CPAP and that's your only option, like start with oxygen, like make sure that they are satting their 88 to 92. Make sure that you're treating hypoxia, start with that. Treat them quickly with the bronchodilators and then like look at your patient. And if they are air hungry or if they are pursed lip breathing and CPAP is all you have, go there. Coach them through it and get them comfortable with it. And most of the time that will be enough to Band-Aid where you need to go.
Hey, what numbers are you looking at? Because I see a lot of people chasing numbers. So in the hospital, are you looking at blood gases predominantly, or clearly you're looking at SATs? But do you look at end tidal, or what do you do?
For a spontaneous breathing patient, I don't normally look at end tidal at all. And I think a lot of it's
For
because
that, everybody, but I'm the idiot here.
I don't, especially like when you're looking at nasal prong and tidal, like you're realistically pulling some. There's entrainment from Romer. If you're giving them oxygen concurrently, then you're going to be diluting the end tidal that you're pulling. It's a side stream. It's going to be like 8 seconds behind. Like all these things are implicating. And like these patients, you're giving them oxygen. So whatever value you're getting is going to be wildly off. So at the end of the day, I'm using my gut. What do they look like? How are they doing? And
Boom,
treating them from there.
boom. I mean, I've said it before where like they're like, oh, our pulse ox is 100%. It's like we have a non-rebreather mask on them, but they're still sick as shit. And then I've had COPD patients I've treated, they're at 86% and they look super comfortable.
Yeah.
It's just, I think people get in this bad habit of chasing numbers. And I, I know people get mad at me because I sometimes shit on these nasal end titles. I mean, they have their utility, but they're not the end all be all. And you don't
Oh,
always see that shark fin waveform.
no, no. Like,
The people
I,
say, "Oh, there's no shark fin." Like, they're
yeah,
wheezing. I mean, what do you want?
yeah, yeah. And realistically, like, unless you have a closed system, you really shouldn't be focusing on end tidal patterns like that unless you truly know beyond a shadow of a doubt that you're getting accurate readings. At least with an endotracheal tube, you're getting that. Like any type of non-invasive ventilation, throw any number out the window. Like don't even put it in line. Like I use end tidal, non-invasive end tidal to ensure my patient is actually breathing. That is it.
100%. I was going to say that. I think they are fantastic for when you get that drugged up, combative psych patient that you unfortunately need to give a shitload of ketamine to like save their life and render them safe to get them to the hospital. Then end tidal is fantastic to let them sleep and make sure they're breathing.
Yep.
But yeah.
Yeah, absolutely. I can't stress that enough. Like, and title is great when it is used appropriately, but over reliance on and an obsession with numbers is going to work against you. And for these COPD patients that are very fragile, the frequent flyers, like ask them what's their normal, chase their normal for when it comes to SATs. Because these COPD patients, I guarantee you, they will know. They will
Oh,
know.
totally. Totally.
So
Totally. I
like,
was 92% earlier. I thought I was good.
yes, exactly. So if I have a COPD patient that tells me that their normal is to sit at 94, that's the number that I'm going to be aiming for, because that's their normal. That when they're sitting in the living room watching TV, they'll throw their sat monitor on their finger that they got off Amazon, and they're like, "Oh yeah, normally I'm 94," and then like you can go from there.
Also, don't freak out at a little hypercarbia.
Absolutely,
Like,
absolutely.
this is also normal for these patients, and they say it's a little neuroprotective.
Yeah. So as well, just reminding people that when you're dealing with COPD patients, even if I have a blood gas, like it's not CO2, it's not PCO2 that I'm chasing, it's pH. And they definitely have an elevated bicarb. They have compensation in place. So it's not abnormal for a COPDer to come off the street, walk in-ish, be short of breath, and have a normal pH, but have their CO2s in like the high 60s. That is totally normal for them. So chasing pH is our as where we are really going.
Excellent.
You
Good.
good there, Mike?
I feel like one of these COPD patients. This is freaking torture.
Mhm.
All right. Well, let me stop this quick. Thank you for coming on. Everybody, this has been Melody. Thank you for coming back on. All right.
Anytime.